So I think we'll start the course proper. Now, my talk is on pathology and pathogenesis. It's just to give you an understanding as to what goes on in the fetal eye that predisposes it to ROP. ROP has been identified based upon many experiments on cats, the vascularization of the cat's eye, as well as on the ROP model of a mouse and a rat. It's called oxygen-induced retinopathy, OIR. Okay. The OIR model, which is both in mouse and rats. There's a difference in the mouse model and the rat model because the mouse model doesn't replicate all the phases of the human ROP, while the rat model is a little more closer to the human model, human occurrence of disease process. So basically, it's a biphasic disease. There are two phases in the development of ROP. The first phase is characterized by lack of physiological development of retinal vasculature because the child is born premature, and we know that it's only a term that the entire retina gets vascularized. So when they are born premature, the peripheral retina is without its normal blood supply. That doesn't mean it's a disease. It's just that they are born earlier than they should have been born. That is the lack of physiological retinal vasculature. Then you give hyperoxia or hyperoxic fluctuations, because studies have shown that hyperoxic fluctuations are more dangerous than persistent hyperoxia. So hyperoxic fluctuations induced vasoobliteration, means the already formed vessels tend to collapse or tend to get damaged, the endothelium gets damaged by the hyperoxia. Both of them lead to a large amount of retina which is avascular and ischemic. Then comes phase 2 as a response to this ischemic retina, and this can occur anytime between 3 to 4 weeks after the birth. And this is characterized by vasoproliferation. And the vasoproliferation can be normal, in which case normal vascularization takes place, the child doesn't develop ROP. But ROP is characterized by anomalous or abnormal vasoproliferation from the retina instead of going into the normal retina as it should go. So the potential factors that influence ROP, we all know birth weight and gestation age are very important. We know that less than 1500 grams the risk is higher, and above 1500 grams the risk is very low. Gestational age also is very important. Less than 32 weeks used to be, less than 30 weeks used to be the cutoff point. Now they say 32 weeks. Neonatal care, what kind of care they get is also very important. I won't go into the details of that. That's beyond the scope of this course. The nutritional status both of the child and the mother, like anemia of the mother, can be reflected in higher risk of ROP. Unregulated oxygen administration, which is probably the most important reason why you get ROP so much in India and the developing countries, is unregulated oxygen. Then heritable factors, there may be a genetic predisposition as well. Previously they tried to blame on Norris gene, but that has not been replicated. There's one study in Kuwait which showed that Norris gene, if a polymorphism or SNPs, could be associated with higher risk of ROP, but that has not been replicated elsewhere. But now they are looking at other polymorphisms, including VEGF polymorphisms, VEGF gene polymorphisms. So a word about vasculogenesis versus angiogenesis. If the vessel is formed around the disc up to zone 1, it is from the precursor cells, not from already formed blood vessels. So the precursor cells, which is like the mesenchyme in the eye, that gives rise to blood vessel formation in the outer retina. And these form the plexus which are up to zone 1 at the most in the adult human eye. And that zone 1 area is vasculogenesis. That is not under the influence of VEGF. Angiogenesis is beyond that. The blood vessels form in zone 2 and beyond is by angiogenesis. For already formed vessels, the endothelial cells proliferate, giving rise to new vessels. That is under the influence of what is called as graded VEGF response. That is the area of retina which is just beyond, doesn't have blood supply. It generates physiological anoxia, and hence it produces VEGF in a controlled fashion. And this controlled fashion VEGF liberation draws the blood vessels towards it, and they keep growing. As anoxia is eliminated, the hypoxic stimulus is gone, VEGF is down-regulated, so no more VEGF liberated at that point. But VEGF again is liberated beyond that, so it keeps on progressing. That is how normal vascularization takes place. But in hypoxia-induced factors, because of the hypoxia, there is an anomaly between the interaction between the growth factors like IGF-1A, etc., as well as VEGF. There are multiple interactions, some upregulating, some downregulating, etc. Some required at a particular point of time and not there, but they're coming at another point of time when they are not required. So these are the reasons why you get the abnormal vascular proliferation. So this cartoon gives you an interplay between various factors, repeated oxygen fluctuations, increased VEGF signaling, then NADPH oxidase, etc. You can see that there's so much of interaction, that is feedback mechanisms, some understood, some not well understood, involving VEGF, involving erythropoietin receptors, Mueller cells, photoreceptors, etc. and various other genetic parameters which we do not understand as of today. So this is just as of today understanding, which indicates to you the tremendous interplay between so many factors. I won't go to the details of that, that's all molecular biology. But what it has, that understanding is given way to is where we can intervene by way of treatment. One is pan-VEGF inhibition, which is being currently done. Targeted knockdown of the Mueller cell-derived VEGF. Some people thought that a Mueller cell-derived VEGF is more important than the general VEGF present in the vitreous cavity. So they tried to target just the Mueller cell-derived VEGF by using genetic therapy in rat model. Then they found that the damage to the neuroreceptors is very high in this model. So as a secondary effect of Mueller cell death, the retinal photoreceptors also die. So there is a lot of damage to the retina as a sequelae of the genetic therapy of Mueller cell knockdown. So this is perhaps not the best way approach. Still we rely on pan-VEGF blockade. And another approach is the normalizing IGF-1A and insulin growth factor binding protein 3 levels in the blood. So some studies have shown that by normalizing it to the intrauterine level, you reduce the VEGF response, abnormal VEGF response. And the use of omega-3 fatty acids and antioxidants have been tried, not very successful, but this is probably something to look forward for the future. I think I will stop my presentation and we'll go ahead with questions and answers.